Okay, so let's talk about opening the airway. So, when you come on scene and you have a patient and you've made sure the scene is safe and you're protecting yourself and all that, and you actually first make patient contact, the first things you're going to look for are airway and bleeding control. Now, one thing that's maybe new if it's been a while since you did some EMS training, the bleeding control is going to come first if there's life-threatening bleeding. So, if you see bleeding that requires a tourniquet or direct pressure, basically if you're seeing puddles of blood or any bleeding that could be life threatening, you're going to go ahead and treat that bleeding first. But once we have that bleeding controlled, we're going to jump straight to opening the airway. Now, as a little side tangent, I used, let's see, Microsoft PowerPoint has a designer tool that they use for PowerPoint. And I let them choose my backgrounds here. And I kind of found this a little bit funny. When I put in the title, Opening the Airway, these are the options they gave me. They were all pictures of airplanes. So when they think of airway, they're not thinking of a human airway, they're thinking of the airways and like airplanes and stuff. So you'll see some kind of funny little backgrounds throughout these different presentations that I got a little chuckle out of. So manually opening the airway. Remember, there are two ways to open the airway. We all learned this in our basic training for EMTs, or even if you've done first aid and CPR. You have two ways to open the airway. You have your head tilt chin lift and you have the jaw thrust. The head tilt chin lift is preferred. It's going to be the most effective way to open the airway. But the problem with head tilt chin lift is that we are going to be moving the neck to open that airway. So if we think our patient might have a possible spinal injury, we cannot use that head tilt chin lift. So if they have a possible spinal injury, we're going to hop down and try the jaw thrust instead. So anybody who has a possible spinal injury, we're going to go for this. Basically, the jaw thrust, you can't really do it on yourself. You have to do it on somebody else to see what it feels like. But you're going to use your basically the base of your thumbs to push against their cheekbones, and then use your fingers to, or thumbs rather, to push their jaw forward. So you kind of go like this, and you're using your fingers to push their jaw forward. On yourself, when you do it, you kind of use your own thumbs and kind of push your jaw forward. But that's basically what the jaw thrust is. So we're just pushing the jaw and the neck is staying aligned. So that's why it's good for spinal injury. The issue is that it does require two hands and it requires a lot of strength to maintain. So if you're holding a jaw thrust on somebody, you're not able to do anything else. You're not able to use the BVM. You're not able to help with applying oxygen, controlling bleeding, anything else. You're stuck there just holding the jaw thrust and holding C-spine, and you can't do anything else. So you'll need another rescuer to help, ventilate the patient, get the oxygen ready, any other treatment that that patient needs. You're just going to be there holding the jaw thrust. Now, if you can't get the airway open with a jaw thrust, ultimately we're going to go life over limb. We are more worried about them being able to breathe. And if we cause their spinal injury to be worse, that's not good. But if they can't breathe, they're not going to survive. So ultimately, it's life over limb. So if that jaw thrust is not working, you may have to proceed to a head tilt chin lift, even if there is a spinal injury. That's what we have to do. We have to get that airway open. So you're going to try really hard for the jaw thrust. You can try using some of the airway adjuncts we're talking about. But if you can't get the jaw thrust to work, just be aware you may need to use that head tilt chin lift in some situations, even if they have a spinal injury. But it's our last resort in that case. So what airway adjuncts do we have at the BLS level? We have oropharyngeal airways, the OPA, and we have nasopharyngeal airways, the NPA. So the OPA goes in the mouth, holds the tongue out of the airway so that the airway remains open. Now to do this, it's going to go all the way to the back of their tongue, and it's going to hit the gag reflex. So before you even try an OPA, you want to make sure your patient's unresponsive. And I don't mean semi-conscious, I mean fully unresponsive. So to do this, you need to go through and check your AVPU status. Alert, responds to verbal stimulus, responds to painful stimulus, or unresponsive. So you need to come up and give them some kind of painful stimulus. You can do the old sternum rub. We all see that on TV all the time. I don't like that one a lot because it's really hard to get enough force, especially if the person's still wearing any clothing. I personally prefer the shoulder pinch. You grab a hold of that trap muscle and give that a squeeze, and that can be really painful. But you're going to maybe even try both of those to see if they don't wake up. If they respond to either of those and they sort of wake up, an OPA is not going to work. They're going to have that gag reflex. It's only for people that were fully unresponsive. But if they don't wake up when you pinch them and give them that sternum rub, you can proceed with attempting the oropharyngeal airway. Now, to use the OPA, you're going to measure it from the corner of the mouth to the earlobe. Now, I'm wearing headphones, so that doesn't really work. But you're going to go from the corner of the mouth to the earlobe or to the corner of the jaw. And that's how you measure it. Once you find the right size, you're going to insert it. I know a lot of people used to insert them upside down, sort of this way. And then as you put it in, you rotate at 180 degrees. Doing that is, it does work for adults, but if you do that to a child, you will damage the soft palate and the roof of their mouth. And for an adult, you're also going to cause some damage into their mouth that I'd rather not have to worry about bleeding and things like that. So instead, I suggest you put it in sideways, basically at 90 degrees. And then as you push it in, you're going to rotate it 90 degrees. So you'll start sideways and rotate that way. So it starts here. Hand up, maybe you can see. Start sideways. And as we go in, we're going to rotate to where it matches the curvature of the tongue. Once it's in, it'll be obviously in their mouth, holding their tongue this way. So I like to start sideways, rotate as you push. Now, as you put that in, you want to be really alert for any signs of gagging. If they start to gag, you want to pull this out before they start to vomit. If you wait till they gag very long, they're going to start puking pretty quickly. So we want to get this out of their airway as quickly as we can. When you put it in, you're twisting it as you go, or using a tongue depressor to hold the tongue out of the way as you push it straight in. But we're worried about pushing that tongue out of the way. So that's why we're putting it in sideways or using that tongue depressor. When you're pulling it out, we don't have to worry about that. We don't care where the tongue ends up. So when you pull it out, you're just going to come straight out, and you kind of come down to follow the curvature of the device. But you want to pull that thing out as fast as you can so that you can hopefully get it out before they actually start to vomit. Now, if you can't use the OPA because they start to gag or they vomit or they respond to that painful stimulus or verbal stimulus, or they're semi-conscious and kind of in and out of consciousness, we can use a nasopharyngeal airway, or an NPA, which goes into the nostril. Now, to measure the nostril, we're going to measure from the nose, basically right where the nose attaches to the face, to, again, the earlobe or the corner of the jaw. As you can see, this one is way too long for me. It extends well beyond the corner of the jaw. Try a smaller one. Go from the corner of the nose. This one's still a little bit too long, but maybe just like a 1/4 inch too long. If it's just barely too long, you can clip the end off. And then this is going to go into the nose. I like to put it in upside down and twist as you go. Now, if you start reading different opinions, you'll see people saying bevel towards the septum or bevel away from the septum. I went on an adventure trying to figure out what this was all about, if it really mattered. And basically what I found is that if you go either way you go, there's a part of the nose that could potentially bleed. So my takeaway from that, make sure that when you're putting these in, you do it gently. Make sure you put lubrication onto the NPA before you insert it. And then as you go, just kind of go slow. And if you feel any resistance, do not force beyond that point of resistance. So that's going to be the best way to prevent bleeding, no matter which way you insert it. Now, these are contraindicated in patients with massive facial trauma. They've kind of backed off on this over the years. They used to say if they have any head injury at all whatsoever, never use an NPA. Now they're saying, you know, a head injury is okay, but if there's facial trauma involved or the actual nose is broken, that's when it's an issue. So just proceed carefully. If you feel resistance, take it out, and you'll just have to go without an airway at that point, most likely. Or without an airway adjunct, I should say. Hopefully we can still keep the airway open with that head tilt chin lift or the jaw thrust. Okay, suction. So we may also need to suction the airway to be able to clear it of fluids that would be in the airway. There are manual suction devices, and then there are portable suction devices that are electric or run off of a battery. These are used to clear the airway of blood, vomit, secretions. I have a hand manual suction device. You just attach a tube, and then you just squeeze it by hand. Each time you squeeze the trigger, it suctions. The manual devices have a catheter on them, and they have a little hole in them. And what you have to do is use your gloved finger to cover that hole to get suction. If you don't cover the hole, it'll suck air in through the hole, and you won't get any suction out of the tip. So you just put your finger over to suction, remove your finger to stop suctioning. Remember that when you're going to suction somebody, you want to insert the suction device into the airway first, then begin to suction, and suction on your way out of the airway. That'll just help remove the secretions or vomit or what have you more efficiently. If you're suctioning and there's just continuous blood or secretions or vomit, or if they're actively vomiting coming into the airway, what you're going to do is roll them onto their side and let the fluids drain from their mouth. So you may have to even use your gloved hand to kind of scoop some chunks out or scoop out, blood or vomit or whatever's in the mouth to get it clear first, and then suction what's remaining. Suction is only going to grab so much. So rolling onto the side, especially while they're actively vomiting, or to initially clear out most of the fluid, is going to be a good idea to start. And then you can use suction to kind of clean up after. Remember, when you're suctioning somebody, they can't breathe during that time. So for an adult, you don't want to suction for more than 15 seconds because during that time, they can't breathe. Even if they're breathing on their own, they're unable to breathe while you're suctioning. So 15 seconds, a child, 10 seconds, an infant, suction no more than 5 seconds. So what do you do if you reach the end of that 15, 10, or 5 seconds and there's still secretions in the airway? Well, use your bag valve mask, ventilate them for 2 minutes, and then come back and suction. Every 2 minutes, you'll just suction out as much as you can, and then we'll ventilate them for 2 minutes to get their oxygen status back up, and then we'll come back and suction again. So you'll just kind of alternate between ventilating for 2 minutes and then suctioning for 15 seconds, 10 seconds, or 5 seconds. Okay, that's what I have for keeping the airway open. Next, we'll talk about actually applying oxygen with the oxygen delivery devices.